All right. Welcome. My name is Leslie Friday, and I'm the Director of Content on the Marketing and Communications team here with Partners in Health. And today's webinar is part of an ongoing series that PIH is hosting related to COVID. And today I'm very excited to welcome my colleagues here for a discussion on contact tracing in Massachusetts, an update from the front lines. We have here with us today Dr. Emily Wroe. Hi, Emily. We have Oscar Baez, and we will soon have Celia Gillis, who is just joining us in a moment. So I will give you a bit of a orientation on Zoom and what's the best options for watching this webinar. So if you are new or if you're old to Zoom, it's good to just view it the best way. If you go up to the top, you'll see there are view options. If you click on that, the side-by-side mode is the best way to view this. Also along the side, you'll see a presentation here in a double bar parallel line. You can move that right or left to widen the screen if you're having trouble viewing the slides. That can maximize everything. And just so you know, we will be recording this, and we'll be sending out the full video to anyone who's interested. I know sometimes this isn't always the best time, so the full video will be available, and we'll also be sharing slides. So if folks want to take notes or didn't catch something, it will be available later. Let's see here. Without further ado, I think I will just introduce folks, and we can jump in. So Dr. Emily Wroe is the PIH Director of Implementation and Design for Partners in Health Massachusetts COVID response. Oscar Baez is a Care Resource Coordinator, and I don't see Celia yet, but once she joins, we'll switch over to her as well, and she is a contact tracer with the Massachusetts team. So go ahead, Emily, if you'd like to begin your segment of the presentation, and then we'll just pass the baton on to each person. And there will be a question and response segment at the end. So feel free to place any questions in the chat box below. We do have some pre-submitted questions, so we'll ask those as well. All right, Emily, go ahead.
Great. Thank you, Leslie, and thanks everyone for having me today. While Leslie was speaking, I was stalking the participant list, and I see many friends, colleagues, and a few family from across the world. So it's really a privilege to get to talk to everyone today about what feels like it started years ago, but really it's been about 90 days since we started contact tracing program to support the state of Massachusetts. And I'm gonna get to give you a little bit of background about what is this program, how is it working, and then you're gonna get to hear the real stories from the front lines from Celia and Oscar after that. So the next slide, Annie, thanks. Okay, so this is the only graph in our presentation because it's the most important graph. And really, we use this slide a lot. You can see Jim Kim's name there on the New Yorker article. Dr. Kim had a lot to do with starting this program way back in March in a conversation that he had with Governor Baker of Massachusetts about how to go on offense against the coronavirus. And the thing about contact tracing is that it's not some fancy new science. We actually know how to fight pandemics, and we just need to do what we know how to do. And that graph shows kind of the influence of contact tracing and supported isolation, which I'll explain. And essentially at the beginning of this pandemic, I know everybody's eyes were glued to the news, and we kept hearing about flatten the curve, right? Flatten the curve, and we were watching these scary exponential graphs. And you can see that data from Wuhan there on the right. But basically what happens is if you flatten the curve, it can look flat, but it can still keep going up, which basically means the virus is winning. And what we need to do to come down the other side of that mountain and to get the curve to actually decrease, or that famous R number under 1, is to do things through strong public health systems that we know how to do for a long time. And that's what we've been working on is contact tracing and supported isolation. So that's what I'm going to get to teach you about today. So the next slide. So this is probably one of our best slides at really showing what is this program and what are we trying to do in the state of Massachusetts. And the most important thing here is to understand that all of these components are really closely linked. we have to do testing. We have to have access to testing for people who need it, and to accompany and facilitate that access to testing so that we can have a lot of people to do contact tracing with. And so people are aware of their self-diagnosis. The second piece is contact tracing, which we'll go into details about what we work on with Massachusetts, and what Celia is going to tell you about after I speak. But the whole point of contact tracing is really so that people know their diagnosis, or they know they've been exposed, so that we can support them in order to isolate and be able to do that 10 to 14 day period, which is really tough in people's lives, right? And asking them to be away from people. And this is kind of how we're trying to build a supportive program to come together as a community. But in doing that, we have to actually stay apart. And so the outcome of contact tracing is to support people to be able to stay in isolation and quarantine. And that support part at the lower right part of the slide is really important. And Oscar's going to talk about our community resource, our care resource coordinators, and how we're identifying vulnerability and making sure that people who have challenges to be able to isolate, that we can accompany them through that. So the next slide. So this is, as with any large complex project, whether we're in Malawi or Rwanda or Haiti or Massachusetts, the partners and people we work with are really important. And so just wanted to show everybody the stakeholders that we've been implementing this with in Massachusetts. So it's all under Governor Baker's leadership, working through the COVID-19 Command Center that was launched with the pandemic under the leadership of Secretary Sutters. And so, as PIH supports governments across the world, Massachusetts has been no different. So we've been working closely with the Command Center and with our colleagues at the Department of Public Health, who we really look to guidance for their expertise, as well as the local boards of health. There's 351 local boards of health in Massachusetts for every official town. And the local boards of health have been doing contact tracing for a range of diagnoses before COVID-19. And then when COVID-19 came, the local boards of health were doing a lot of contact tracing in the communities, and the Community Tracing Collaborative was started to really help with the high volume that we have, and to work with the local boards of health to be able to meet the needs of the population. And then just to note that we work with the Commonwealth Health Insurance Connector Authority, who's worked with the state for a long time here, as well as we have a lot of staff from community health centers. So reaching out to the community through people that are serving the community, especially vulnerable parts of Massachusetts. So the next slide. So, and then this is just, the text here isn't as important, but just to understand that MAVEN is the state database. It's the system of record for infectious diseases in Massachusetts, and it's been there for a long time. It has hundreds of diseases in it, and the local boards of health all work in MAVEN. And then we've set up the Community Tracing Collaborative to work in a different online platform, and those have to talk to each other. So a lot of this project has been about fitting all the data systems together, fitting all the people systems together, fitting the protocols together, and all working kind of toward the goal of reducing community transmission in Massachusetts. So the next slide. Want to give you guys a sense of our team. You have two of them on the phone today. There's three main roles on the Community Tracing Collaborative. We have case investigators who call the cases, the people diagnosed with COVID-19, to talk to them about isolation, about the needs that they have, and about the people they've come in close contact with during the infectious period. And then those people are picked up by contact tracers, and Celia will talk more about that on the phone today, who call people to let them know, they may or may not know, but to let them know that they've been exposed to COVID-19, and help them figure out what they need to be able to do to quarantine for the 14-day period in order to keep the community safe. And then care resource coordinators, Oscar will talk to you about this today, but care resource coordinators have deep experience in local communities in Massachusetts, and really are charged with helping people with any type of vulnerability, including food, housing, and other social situations, to be able to safely isolate. At our peak, we had 1,500 combined case investigators and contact tracers, approximately, and around 150 care resource coordinators. Massachusetts has made a lot of progress in COVID, so that those numbers are lower now and are actually going to be decreasing as well, because we don't have as many cases right now, and we're trying to build a nimble system where we can kind of rise and fall as the need does to support the local boards of health. So we had, over 40,000 applicants, I think, and we're not currently hiring, and that's really a success story of what's happened in Massachusetts. So the next slide. Just to give you guys a sense that that staff I just showed has undergone extensive rapid training. The local boards of health use public health nurses with decades of experience, and there's epidemiologists at the Department of Public Health. So we've really charged and entrusted our staff with going through rapid training through a 4-day period at the beginning and when they get hired. And then we do a lot of ongoing training in topics ranging from public health protocols to psychological first aid and learning how to support somebody on the phone who's in distress. So the next slide. I'm not going to go through this in detail. These slides are going to be made available. Oscar and Celia know that any contact tracing program has lots of flow charts, and so this is really just showing all the steps that somebody either diagnosed with COVID-19 in Massachusetts goes through and how they interact with our team, and then some people who are exposed, the contacts. So they receive many phone calls from us. They get that first phone call to do an in-depth interview for cases to gather their contacts, and for contacts to let them know they're exposed and arrange testing. And then we call them actually many times throughout their isolation and quarantine to check on them, make sure they're doing okay, and see if they need the support of the care resource coordinators if families are living in overcrowded housing or have run out of food or have other challenges with accessing care, for example. So next slide. And this is just to show that it's a very dynamic back and forth partnership with real-time communication with local boards of health. And what we're aiming to do and what we're doing is that the Community Tracing Collaborative was able to help with this large surge in Massachusetts and doing a lot of the contact tracing. And then for specific complicated situations where we need to lean on the local boards of health and their expertise in epidemiologic investigation, if we find somebody who's in a nursing home and there's a ton of exposures and it's a scary situation, we refer those back to the local board of health. The local boards of health are often taking care of the healthcare workers, where the rules are a little bit different about when they go back to work, as well as they're the ones that are investigating clusters. So this is a real back and forth dynamic partnership, both with human to human communications. Our teams have been geographically based, so our supervisors have really gotten to know the local boards of health, and then the data systems are talking to each other on a daily basis as well. So the next slide. And just some numbers to throw up for you here. We've dialed on the phone more than 325,000 times by today, probably more than 43,000 cases and contacts. The pickup rate, we've all learned a lot of call center operational terminology, but the pickup rate, which basically means the percent of times we dial and somebody answers the phone and talks to us for more than 15 seconds, is currently 73%, which is a real testament to the outreach the team has done in a lot of communities in Massachusetts that I think Oscar will cover in more detail as well. And then right now we're completing initial outreach, that first in-depth interview with almost 90% of the people we reach out to. And under 10%, since mid-May, under 10% of people are kind of people that we're never able to get a hold of. So, we're continuing to improve these numbers, but these represent a lot of improvement, a lot of effort at community outreach, and a lot of success for the Community Tracing Collaborative. And then we've also been able to support almost 70% of people completing isolation and quarantine through those kind of daily touch points and the resource coordinators. And the people in that other 30% aren't all bad outcomes. A lot of them are getting referred back to local boards of health for those complex scenarios. So the next slide. And then just a note on the care resource coordinators. I think I'll leave this mainly to Oscar, but this is really represents, PIHs and the states and everybody's commitment to human rights and social justice, and understanding that if we're making this huge ask for people to stay in isolation or quarantine in order to protect themselves, their community, their families, that we're obligated to make sure we can take care of them during that time period. So next slide, Annie. I think I'll leave that to Oscar. You can keep going. And then just some data before we hear from Oscar's experience is we've had more than 10,000 requests for social assistance. This is as of the middle of last week. About 20% of the cases are getting referred to a resource coordinator right now, and 6% of people are reporting they feel unable to self-isolate and quarantine and really need that support. And you can see the needs there by type, that food is the most common type really across the state, and that other is the next most common type, and often with a lot of things that relate to specific financial stressors during this time and during life in general. And we know that this pandemic has uncovered and shown a light on a lot of the structural violence and structural injustice that exists in our society at baseline, and that we're seeing that play out in Massachusetts. And so we're really trying to address that through our programming. Oh, next slide. And that's just a website for more information. So thanks. It's really been great to speak with you all. Looking forward to questions. And I believe I'm going to hand over to Celia, our contact tracer, on the phone.
Okay, can people hear me? Can you hear me? Okay. So my name is Celia Gillis, and I have been doing contact tracing since about mid-April. So basically when the first wave of hirees started to work for Partners in Health and the state of Massachusetts. I have a background in nursing, and although I hadn't worked for many years, I really wanted to do my part to try to shorten the crisis. And I really had no idea what it was going to entail, so I was really thrilled when I was hired. So a little bit about sort of the day-to-day work. I log into a database of cases, which appear as a list of case numbers, and those are the contacts that are generated from the calls that the case investigators make to the positive cases. So my job is primarily to call these contacts and to inform them of their exposure, to provide really clear quarantine instructions and advice, and to document any symptoms they may have, and to refer for testing and suggest they see a healthcare provider if necessary. We also assess any resource needs that they may have in order to safely quarantine at home, but I know Oscar is going to speak a lot about that. So we are also provided with a script for these calls, but I have to say they're very rarely straightforward. There may be at-risk household members, it may be a family of 5 that's sharing one bathroom. I've learned so much from these contacts, mostly that 14-day quarantine can be a really big ask. I think so many of us don't realize that. You never know who's going to be on the other end of that call. If they could be hospitalized, they could be a primary caregiver to another individual, they could be homeless. So for the most part, I've found that the contacts really want to do the right thing, and I try to keep in mind that I'm there to provide them with the best information I can and with recommendations. So one of the biggest surprises, I think, for me as a contact tracer was that I thought I would just be calling a list of people and letting them know their exposure. I didn't realize that I'd be following up with them for 14 days for the duration of the quarantine. So this piece came to be really important to me. I like to think of that first phone call now as sort of just building the relationship, because they're often scared or angry, and they want to know sometimes who reported them, which the other day I called someone and she was really upset and she wanted to know who reported her, and obviously I can't share that information, but I just tried to say, maybe don't think of it as being reported. I like to think of it as someone cared enough about you that they wanted you to know. You might have people close to you that you need to protect and keep safe, and I think that that's probably what that person had in mind when they said that they could have exposed you. So it may not be that first phone call that you can make a difference. And so for me, I feel like now knowing that I have, 14 days that I can keep trying to get information to them and keep reinforcing it. It's really how the relationship builds. And more often than not, they're really grateful to know that you're going to be calling them in 2 days and checking in on them. Because I always tell them, you could get symptoms if they're fine now, so I think they know now that I'm going to call them and check on them. And for the most part, they've been really receptive to it. I had a young man once who was really upset. How was he going to stop work? He needs the job. And, all I did was, reinforce, why we're doing it, like who is at risk, what a difference you could possibly make. And when I called him back, he had actually checked himself into the Hope Field Hospital for quarantine because he didn't want to risk his older mom getting sick. So I think those are the experiences that you really feel like you're making a difference. And it's also those relationships that I didn't anticipate when I started the job. You talk to people and they're doing the most that they can, and it may not be the ideal, but I'm grateful that they allow me to continue to follow up with them. So I think moving forward, I think that relationship is really the valuable piece, because it's not going to get easier, I think, to ask people to quarantine. People are getting back to work and they're getting back to life, and I think having people calling them if they've been exposed and reinforcing and reassuring them is really what can make the difference. And I know at the end of my phone calls, I always thank them for whatever it is they're doing, because I know I'm grateful, and I try to think how would I feel and what would I do if I were getting that phone call. So that's pretty much what it's been like, and I hope that shed some light on it for everyone. Oh, and Oscar, I'm passing on to Oscar, who's going to tell you so much more about what we do.
Thank you so much, Celia, for giving us the perspective on, again, what the contact tracers themselves are doing. I think this is an excellent opportunity for us to all see kind of the life cycle of what the contact tracing program is and how we're really accompanying. If somebody hears on the other end of the phone, they get a call and saying you've been exposed to COVID-19, and it's already beginning in a moment of fear, uncertainty, and we really like in PIH to apply the model of accompaniment. As Emily said from the beginning, we care resource coordinators. We've received so much training to make sure that we approach this work from a human rights perspective. Healthcare is a human right, irrespective of your zip code. And a little bit about me and why I care so much and know how urgent this work is and continues to be. So I was born in the Dominican Republic in Santo Domingo, but when I was a baby, my family immigrated to inner city Boston. So I grew up in Boston. I'm a product of Boston Public Schools, K through 12. I actually grew up in public housing in various neighborhoods. Roxbury, for those of you that know Boston, Roxbury, Dorchester, still have family in Hyde Park. The very neighborhoods that were disproportionately affected when the pandemic hit Massachusetts and hit my home city. And ironically, I have a background in public policy, and I not in public health. However, through my own kind of background, I feel I've grown up with a social work background because of what I've experienced in the communities, specifically immigrant communities, and the traditionally excluded communities throughout the country. We've known how the pandemic has laid bare systemic inequalities and actually exacerbated, as we said, quarantining safely, that's a privilege. Being able to stay home, work remotely, go see Netflix, that's a privilege. We're asking people to stay home for 2 weeks or more and survive this quarantine. And that is a huge ask. And I signed up for this. Interestingly enough, in 2010, I was visiting my own family in the Dominican Republic when the Haiti earthquake struck. And again, Dominican Republic, we share an island with Haiti. And immediately, PIH was already a global leader. It had its start in Haiti in the response for the crisis, and subsequently even the cholera outbreak. So I saw at that time, I signed up because I knew I had some local knowledge of the Dominican Republic and how we can procure emergency supplies to Haiti. And I was just so impressed by the global leadership that PIH had at that point. So when there was hiring in the first cohort for care resource coordinators, I said, I want to be able to apply this global health framework in my own city and use my own knowledge of what my own community needs in this unprecedented time and crisis. So I just want to briefly give an overview of how I view the care resource coordinator role and just very concrete examples of what I've seen, you know, on a typical day, on a typical week, as we try to accompany these individuals through a very difficult time. So again, care resource coordinators, after the contact tracers like Celia have already reached out and explained how to, you know, isolate if you are a contact that was already confirmed to be positive with COVID, or if you are a case, or if you're somebody who receives a phone call from our team saying you may have been exposed to the virus, this is how you need to quarantine. There's a home assessment part in that initial conversation where we try to figure out as contact tracers, what are your needs? Can you have food the next day? Do you have the ability to safely isolate and not infect and make those who you're living with also sick? What's your financial situation? Can you afford to be in isolation for 2 weeks? And primarily, oftentimes in the first call, maybe symptoms are just starting, but by the second call, third call, they could either be getting better or worse. And so we're making sure that they still have access to care. And to give you kind of an idea of what that universe can be in terms of social support, sometimes it can mean, I'll just go through just honestly cases I see on a given week. One of my very first cases was, again, a lot of the cases we saw early on were in congregate settings, so nursing homes. And so it was just a senior who wanted to speak to somebody about how to, you know, continue to monitor her symptoms. Her husband was in the hospital. She did not speak English. She was just so grateful to hear from someone to check in on her, as her husband, who was in his 80s, was hospitalized at that point for a 2-week period. And, you know, just provide that support. Even though she health-wise was okay, she needed that support. And we got training in psychological first aid, as Emily mentioned. So just being that human contact on the other end. Again, there are lots of technologies. Contact tracing is a critical tool to flatten the curve. There are apps, geotagging, et cetera, that have worked elsewhere, but there's no replacement for just somebody to give you a call and say, how are you doing today? I know we spoke a couple of days ago and you said that, you know, the fever was starting to get a little worse. How are you feeling? Starting from that human connection is so critical to reassuring the person. But there are also very, very complicated cases that I've seen in my work. So a nursing assistant tested positive, said that everyone on her floor in an assisted living community, all of her colleagues also tested positive. And she had no way to pay for medication. After she was released from the hospital, she didn't have insurance. So we had to work to make sure that we could provide you know, a pathway to make sure that she got insurance, whether it's Mass Health Limited, and just made sure she had access, you know, to testing and prescription medication as needed. And we actually work with a lot of mutual aid groups throughout the state who have stepped up. You know, I'm on team 8. As Emily said, we're geographically divided. So Boston specific, and we call ourselves Boston Team Great, Boston Strong, because we've seen how the city and the state has really stepped up. Volunteers who are willing to do that delivery for somebody that can't leave their home, even if it's, you know, around the corner getting food at a food pantry. A volunteer works with us, and we put them in touch directly to make sure that they can get that prescription. They can get that food delivery immediately or as soon as possible. And so I've seen cases, again, that's daily, that's a need for food resources or for medication. Another one that stuck with me early on, I grew up in a daycare. My mother was a is a care in Massachusetts. She's a licensed daycare worker. And as we all know, they were all closed during the pandemic. And there was a specific list of daycares that were made available specifically to frontline workers. So we had a case whose mother had taken care of her 11-month-old baby. Her mother got diagnosed with COVID and passed. And then this own case was also diagnosed with COVID. Luckily, the baby never showed symptoms. But this is so incredible to me, how resilient this person decided, to go back to work and fight this pandemic on the front lines, even after she tested positive. But what was he asked from our team? Now I need somewhere for my baby, my 11-month-old baby who's going to turn 1 next month, to have a daycare close to hopefully to where I'm working. It's incredibly heartbreaking. And the fact that we knew those resources provided by the state and made a priority free of charge to this person made all the difference. And again, there's long-term psychological impacts that we want to accompany them throughout, but we just want to make sure we can hold their hand through this initial moment of crisis. I've had calls from pregnant women or families who have newborns who say, we need baby formula. How are you going to ask me to stay home for the next 2 weeks? We're unemployed. Some of them undocumented, and they confide. We never ask for that information, but they confide in us, all of the struggles that they're facing. How can I get baby formula? So we've worked with this state, whether it's getting masks, PPE, something like baby formula delivered and paid for either through the city services, municipal, or again, in collaboration with the local boards of health. And the list goes on, and it can be quite depressing. Some cases I've had where someone is uninsured, unemployed, victim of domestic violence, and doesn't know how to continue to seek that kind of care and support. Oh, and then minor detail, they don't speak English. So oftentimes there's a digital divide. People, even though there are lots of websites and resources out there, we have to make sure we translate that through the digital space to them on the phone. And if there's a language barrier, work with our interpreters, or if we ourselves have that capacity to speak directly. And not just because of the language barrier, but culturally being there to let them know that we're here, again, in terms of solidarity, to support them, but because we're all in this together. And so I think that just provides kind of a somewhat of the universe that we're dealing with, whether it's housing, safe isolation sites, food delivery, and that's something that's critical. So I'll just close. I'm sure you have many, many questions. But for me, I'm incredibly proud as a Bostonian, as an immigrant, of the work that this pioneering initiative has done. PIH, I know, with the state of Massachusetts, was one of the very first, if not the first, state in the country, early April, to launch such a comprehensive program on contact tracing. And I know it's now serving as a model for many other states who are ramping up. It's never too late. It's never too late to look at these issues, systemic issues, in the context of the pandemic. And hopefully our experience, again, we want to work ourselves out of a job. And I think we're doing that. And I'm very happy about that. But we've had a really intense experience. Again, 90 days, it feels like over a year at least for probably all of us. But if our experience can serve to prepare for, if there's going to be another wave, we'll be ready. And if other parts of the country are actually at the peak of their cases, if our experience could at all serve for anyone listening to help inform those efforts, I'm just incredibly proud to have been a part of this, specifically for helping the most at-risk. I think I've heard some PIH leadership saying it's very obvious that this pandemic has impacted disproportionately, communities, ethnic minorities, the traditionally excluded and vulnerable. At the same time, as a result, this program has been set up in a way that we need to disproportionately deploy resources to these communities. And it is through this, life cycle of contact tracing accompaniment, what Celia does, what I do, what the contact investigators do, all together, through this period to make sure that we can continue to support our communities, not just immediately, but also short, medium, and hopefully provide public health infrastructure solutions for the long term through what we've experienced. That's all for me. I'm so happy to answer any questions you may have.
Thank you, Emily and Celia and Oscar. This has just been a great presentation. I feel like I've learned so much, and I work at PIH, so this has been great. So I'm going to start with a mix of pre-submitted questions and then kind of combine some questions that are coming in across the chat. So please feel free to add those if you are listening and want your question to be answered. I think the first one, Emily, I want to send your way, and you address this in your slides a bit too about the effectiveness of the contact tracing initiative. I think the statistics you shared were really important, but how do we know that this is working, right? I think one thing that I've been looking at too is how the curve is compared in Massachusetts versus other states, and if we can assume that means what we're doing is hitting the mark.
Excellent. Yeah, no, that's a great question. And when we think about, is it working, there's a lot of different ways to think about that. Early on, we were really focused on making sure that we could kind of hit I like to think about it as like comprehensive, timely, and equitable. And so early on, we were really focused on how do we get a hold of everybody, right? And I mean, for people on the phone, when you get a call from an unknown number, like, is your reaction to pick up the phone? Probably not, right? We screen. And so we did a lot of work that ranged from sort of protocols around how many times to call and what time of day and what do we say on a voicemail and having caller ID, to working with mayor's offices and local boards of health to reach out to especially at-risk communities in the community, and then a big media campaign, a lot of things that we did to try to just increase getting a hold of people. And we've had a lot of success there. So we really are getting a hold of over 90% of people at this point. And the other things we're really thinking through is trying to make sure that we can support everybody we get a hold of to effectively isolate and quarantine. So that was the like, it's something like 70% number that I showed, where we actually are following them through the entire period and helping them successfully reach the end of isolation and quarantine. So that's another one. And then another is just how quickly are we getting a hold of people? So this virus in particular is really infectious toward the beginning. And so the faster that we can get a hold of people in those first days and then get a hold of their contacts, the better we're going to be able to protect people. And so we're doing a lot of things to work on that. And right now, once the data hits our system, we're calling everybody basically the same day that we get that data. And then the bigger picture things are a lot of what Oscar was speaking about, and making sure that all of these results we're looking at from an equity lens, and making sure that ethnic minorities, that people who don't speak English as a first language, like that we are, and that there's geographic vulnerability, that we're making sure to kind of look at the different vulnerable communities and that we're achieving the same outcomes there. And that's work that's in progress. And then ultimately we want that R under 1. And we also want things like, we can't measure this yet, but we will be able to soon. If Massachusetts didn't have open borders, every single person who got diagnosed with COVID-19 in Massachusetts would be a contact in our system. If we chased down every little piece of the virus, we would sort of know them already, right? Because they'd been exposed. And so the higher kind of the proportion of new cases that were identified as contacts, that kind of means the more comprehensive the program is. So there's a lot of different ways to measure and think about this, and a lot of work going on in that right now. And we're working with our partners at the Department of Public Health to combine our data with the local Board of Health data, so we can see contact tracing broadly in the state of Massachusetts, and look at some of those bigger picture metrics, and then having a conversation about what might it look like to estimate the sort of relative contribution of contact tracing in Massachusetts compared with all of the other great policies and efforts of the communities, the sacrifices people have made. So I think we're working on that actively right now. So thanks for the question.
That's great. Celia, actually, the next question I was hoping to send your way is, what are some of the hurdles you face in contact tracing? And I guess in combination with that, someone else had asked about what about folks who don't have phones or easy access to that kind of technology? If you could talk to those hurdles.
Sure. So, boy, it's a big scope of hurdles because, but I think also while there are hurdles, I think the platform and PIH have really worked so hard to try to think of everything, and just a little bit about what's incorporated into that database. There's a whole training section, there's a whole communication section. So I feel like, first of all, when there are hurdles, there are people that you can rely on to address the questions, and there are resources that are really literally at your fingertips. So I think some of the hurdles, obviously, when you don't have phone numbers, they also have special units that are dedicated to tracking down people that we don't have either accurate phone numbers for or no phone numbers at all. And sometimes that's referring back to the positive case and seeing if they can help us find accurate phone numbers for contacts. And sometimes that's getting it back to the local Department of Public Health so that they can try to track down things that we just don't necessarily have the feet on the ground to do that part of it. Also built into the platform is like access to a language line where we have really a huge number of bilingual contact tracers as well, but I think a lot of people could see that as a hurdle, but they have thought of that, and there's a language line built in that we can literally access an interpreter for any language to talk to people that aren't primarily English speaking. Other hurdles, I think Oscar addressed a lot of the resource needs that are hurdles. We talk to people that are hospitalized and homeless. Individuals, we have resources that they can quarantine in, temporary quarantine facilities. So I think those are some of the hurdles. I hope that sort of gives a good general scope. It really is all encompassing, and it's just one of those things where you really never know who you're going to get on the other end of that line when you dial it. So it can be a little intimidating, but I've found for the most part that they've really thought of where we can go to get the information we need to best serve the people we're calling.
That's great. Fantastic. Thank you, Celia. Next question, I think, should go to Oscar, actually. And we've discussed some of this, but there are also a number of questions in the chat about particular populations that are quite vulnerable, in particular, what you mentioned, undocumented immigrants. So I guess kind of two parts here. Has there been any pushback or nervousness about contact tracing technologies? I remember you saying before the call that you're on a working group talking about some of the technology and access to folks, and then also marginalized and undocumented people. What do we do in those cases? And anybody else too who wants to jump in, please do. But Oscar, what do you got to say there?
Yeah, thanks for the question, Leslie. So again, in terms of our work, PIH early on identified that, the goal is to reach every single person diagnosed with COVID-19 in Massachusetts that is in the database. However, there are specific barriers that exist and extra barriers depending on certain groups and certain challenges that became clear resource needs early on. So we had now working groups that look specifically at immigration and challenges, be it linguistic barriers, legal barriers, the digital divide, which I mentioned, that immigrants face in addition to just trying to find care during quarantine and get through this period. There's a working group on accessing benefits. So if it's, again, the financial stressors, unemployment benefits, seeking for the first time a PCP, so a primary care physician, finding a way to get insurance. So there were working groups specifically for those areas, and in addition to dealing with substance abuse and violence, be it domestic violence or otherwise. So I'm the chair of the Immigration Technical Working Group, and this is something that I look at contact tracing generally as going on the offense. So Boston is very much a sports town, the state, and I think defensive measures like stay-at-home orders and social distancing are critical. But it is, again, I think, what we can do to, defend ourselves. Contact tracing goes a little further, right? We're actually proactively reaching out, tracing where the virus is spreading, and making sure that we can stop that proactively. And so we're doing the same thing in terms of our own community outreach. When we first launched this initiative, of course, there's fear of scams and, how is my personally identifiable information going to be used? And there obviously is a kind of a distrust of systems depending on your personal experience with it, and as we all know. And so proactively, the organization has what we call myth busting campaigns, just making very clear that we will give you a call, but we're here on the other line to support you. We have information only that we received through the Department of Public Health because you tested positive. So during that test, we got your date of birth and your demographic information, just basically where you live. We're not going to ask anything about your social security number, bank information. So we made clear actively in various languages that we would never ask that kind of information. We just need the essential information, your address, because we're going to deliver food to you, hopefully, if that's your need. And also for me, I've had cases where, if someone is undocumented, we never ask that. We're here to support regardless of your status, migration status. But when it does come up on their end, it's through fear. How can I access testing? Am I going to be turned away? Or I actually have documentation, but I was told that there might be a public charge if I access quote unquote welfare. Does that mean ultimately I can't become a citizen? So we dispel all of these myths and we let people know there's kind of a know your rights campaign. Regardless of your migration status, you have a right to quarantine safely in your home, even if someone is threatening to evict you. You have a right to access, sources from a food pantry that they're not going to care about your migration status. So building that trust is really critical. And we've been proactive on our working group. For example, I've gone on radio interviews in Spanish in Lynn, in Western Mass, Lawrence, getting that word out directly, either by radio interviews, as I said, or other webinars that we do with basically virtual town halls. Because without that trust, how can we ask them to give us such personal information? But again, if we don't build that trust, we're creating a barrier for them to access these critical resources. So again, it's an effort where I think it has to be proactive, and we're seeing cases again in other states where the community disproportionately affected are those that might already have a distrust, with authority, with systems. So we really have to be very clear about communication early on.
That's great. Thank you, Oscar. Next question to Emily. We're getting a lot of questions about please come here. Basically, if I could summarize, where else do you work? Are you going to work outside of Massachusetts? So for people who might not know about our broader response, could you maybe address that, as well as the fact that we continue to work on this globally, right? This is not the only thing that we're doing. So maybe if you could talk about that and tie in a bit of the research, if we are doing any research to share with other folks about lessons learned.
Yeah, definitely. It's interesting when it was kind of late March, we were putting this program together, and contact tracing was not, it really wasn't on the agenda in the United States, and it was not getting talked about, and there was a lot of skepticism. And it's been really inspiring to watch that conversation change over the last couple of months. And so there are a lot of states with contact tracing programs now. We have what we call the U.S. Public Health Accompaniment Unit, and a lot of people who've historically worked with PIH and new people who have joined the team that are supporting a lot of states. So the Massachusetts team is, up to here in the work in Massachusetts. And then there's a large team supporting several other states through different partners and through state governments. And there's definitely people that you can reach out to. So I'm going to give you an email. I'm seeing Joya in the chat. So Kelsey Soderberg, KSODERBERG at pih.org. If there's other states or groups that want to be able to do contact tracing. So you're welcome, Kelsey, for just giving everyone your email address, but there's definitely a large response with a lot of other states where we're taking lessons learned globally and lessons learned in Massachusetts to support other states. So one big team. Yeah.
That's great. And maybe an extra plug too, as part of those efforts, there's the Learning Collaborative where we're sharing some of this information, and you can, as a public, anybody can sign up for information about this. I don't know, Emily, if you wanted to add that. I feel like we are going to be doing research, but I may be speaking out of turn here.
Oh, sorry, the research question, I forgot. Yeah, so they're going to send the link for the Learning Collaborative to, I think, everybody on the call today. So I see a note that somebody's going to send out that Learning Collaborative link. So there's a lot of resources there. Regarding research, I think we aren't doing formal sort of scientific research with to like medical research with information we have about COVID patients in Massachusetts. That's really the purview of the Department of Public Health. But what we are doing is using our data to learn about what is working, what is the right protocol for the number of phone calls to make, and what can we kind of do to increase the number of people that we get a hold of and how quickly, and what kind of approaches work on the phone to try to document lessons learned about all of our approaches. So there is definitely an ongoing sort of learning approach and using data both to improve outcomes in Massachusetts as well as to share those lessons outwardly. And that's been going on since the start and is really ramping up right now to kind of learn from all the data that we have. And for kind of dissemination in Massachusetts, of course, deferring to the Department of Public Health on the more policy-driven things in Massachusetts, because they have all of the data, whereas the Community Tracing Collaborative is working with what we're assigned to do under the Department of Public Health. Great,
thanks. And another question that was pre-submitted, but I think is probably a lot on people's minds right now is, the idea of going back to school in the fall, right? So lots of universities and public health school system, private schools are thinking about this. How should universities best plan for contact tracing activities during the upcoming semesters? And I think, Emily, you had said that you've got a bit more information, but anybody who wants to comment on that, I'd love to see if we have something to add.
Yeah, and I mean, I think more broadly, as the economy opens up, we're confronting a lot of questions, challenges, ideas, new protocols right now about how to address, the world beyond kind of the shutdown, right? And that goes from working with the Department of Public Health and our staff on how we're going to deal with people going to the hairdresser who might later get diagnosed with COVID, or to a yoga class or to church. So I think there's a lot of questions like that. And then a very specific piece of that is, Massachusetts has a huge higher education system in addition to a lot of different boarding schools. And that's just the schools where students live. There's a couple different task forces that I know are happening at the state level to talk about this and bring together schools. And we're hoping to kind of offer our lessons learned to that. And you can imagine that this has challenges around standardization of protocols and training, who's staffing it, and making sure the data systems all speak to the state data system so that the broader lens on the pandemic by the Department of Public Health is possible. So what I know is that there's a lot of very smart people working on this problem and thinking about things like routine testing for students at higher education, and then pairing that testing with immediate contact tracing, both on and off campus, and what can that look like, and how does that relationship look with local boards of health, are all being discussed very actively right now.
Great, thank you. And I think we have time for one more question, and maybe each of you can talk about this. There was some comments on the chat and also pre-submitted. How do you convince people to buy into this, right? There's a bit of skepticism out there. Do people actually answer? When they do answer, you know, what's the reaction to knowing that they're positive or have been in contact with someone else. So I guess, what tools or what talents do you use to convince people of the seriousness of this? And maybe Celia, if you want to take that, or Oscar, everybody I'm sure could have something to add.
Sure. I think a lot of the times, I used to call positive cases as well, and I think a lot of times they were expecting it. And I also feel like we are very fortunate to live in a state where we've been given reliable information and access to information. And I think the community response in general has been so positive, and information is so readily available that there are always going to be people that are skeptical, but I also think that's part of the benefit of being able to call them back. If, a lot of times, you know, they'll have questions and I'll say, you know what, I understand you don't want to talk to me about this right now, but why don't you think about what questions you have and I'll call you back tomorrow. And, you know, that sometimes just little things work. You don't have to be forceful or try to be overly persuasive. You know, just say what is it that you're most concerned about. And sometimes they don't know in the moment. Sometimes, you know, it's just their emotions taking over and they just need time to process the information as well. So I think that's really the benefit of not trying to like just force all this information on them immediately, to know that if you're willing to just take another phone call from me, you know, we can take baby steps to get there. That's what my experience has been.
Oscar, anything to add?
Yes, just to add to that, I was once asked, you know, to rate from a scale of 1 to 10 the contact tracing program, and this was, I think, you know, at the peak of the crisis in Massachusetts. And again, this is an unprecedented challenge. When every single time I click on, you know, a case number of a task for a care resource coordinator, it goes from a number to an actual human being that is struggling to figure out how to get through quarantine. And it immediately becomes personal. I had some shifts where they got tested at the local community health center where I had my physical as a kid, or where my dad gets his prescriptions. It is impacting us immediately and directly. And so to me, it's a 10, because clearly statistics show that Massachusetts has done very well in terms of flattening the curve. Of course, we can improve, and we're going to continue to try to do so. But what makes a good contact tracer is just somebody that's there to listen, to be empathetic, to accompany these individuals most at risk, to make sure that they keep themselves safe, but then all of us safe. And so, again, the buy-in, it should be clear, we're all in this together. It's an unprecedented time, and it's never too late.
Fantastic. And Emily, did you want to add anything else, or?
I mean, I think Celia and Oscar are exactly right. I mean, I just would go back to the sort of PIH core principle of accompaniment, and that's really what we're trying to do, is walk with people through isolation, through quarantine, and support communities in Massachusetts. And you know, we're not policing, we're not scolding, we're not insisting or yelling at people or judging or any of that. And it's really meant to be the spirit of accompaniment and a supportive community initiative to sort of all work together to fight against the virus. And that, you know, we try to make that come through in frequently asked questions that we make available to staff, in protocols, in trainings, in working with, you know, a lot of our staff are from Massachusetts, the resource coordinators. There's community health workers from the Massachusetts Association of Community Health Workers that work with us, the community health centers. And so I think it's just community-driven accompaniment and really trying to live that minute to minute during these tough times. So thank you.
Thank you to everyone, to Emily and Celia and Oscar. This has been a wonderful conversation and great questions from everyone. I hope for those of you listening and watching, it really was helpful for you. We will be sharing the full video and the slides afterwards, so that link is also in chat. But for more information, please always visit pih.org, our website. And if you're on social media, you can find us on Facebook and Instagram, Twitter, all the major channels out there. You'll find us. So thank you very much. And if you do have an opportunity, we'd love to have you join us again for another webinar soon.